Welcome back to the Dental Implant Masterclass. Today we're going to discuss a really interesting case of a 46-year-old male who'd received trauma to the front of his mouth, which is not common, but it's also not uncommon. But what made this case particularly interesting, which is why we're discussing it today, is that over and above this gentleman had a tongue thrust, an anterior open bite, very long central incisors, and when he smiled, you could see his entire teeth and his gingiva. And to compound this even further, this patient wanted this restored. He wanted the final work restored similar to the look that he'd always had up to that point in time of his life. In other words, he didn't want to have a case that gave him a class 1 bite. So let's dive in step by step, and I'll tell you how I approached this case and also show you the loopholes and also the pitfalls in this kind of case. No two cases are the same, but if I can share with you some of my knowledge, you may be able to utilize this in the future with similar cases. So let's show you what this case looked like when I first saw this gentleman. So this patient, we'll call him John for the sake of teaching, had an orthodontic wire which extended from the 1-3 to the 2-3 and had some composite attaching it at the 2-3, 2-2, 1-2 and the 1-3. The 1-1 was still in position and had some palatal composite, but this tooth was mobile. The 2-1 was just a plastic prosthetic tooth, or more specifically an acrylic prosthetic tooth. What is important as well to note in this case is that the tooth 2-1 and the 1-1 had previously had a root canal treatment. Now let's look at this view from the front. So this is the frontal view of the patient's mouth. And what is important to note is that we need to record the gingival level of the remaining tooth at the outset of treatment, because this will give you a guide or a target that you need to work against, and look at the level in relation to the adjacent teeth on both sides of the mouth. This is a very important technical point. It is also important to note how long the patient's central incisors were, and also the patient's smile line. So when the patient just very casually smiled, this is how much of his teeth and gingiva that he exposed. So the good news was that John was medically fit and healthy. He didn't take any medication. He had no cardiovascular or any other condition that was being managed. The only thing that he did was take a few vitamin supplements. He didn't smoke. He only drank the occasional alcohol, 1 unit per month, and he was fit and healthy and an ideal candidate for surgery. The patient said that he was well informed and that he had been referred to us because he specifically wanted implants. He didn't want any other solution. We tried to convince him of the fact that there were other treatment modalities, but he had explored all of these, and he was absolutely adamant that what he desired was fixed implant treatment of his 2 central incisors. So we took that into consideration in our treatment planning. So let's dive into this case. So the next step was radiographic assessment, and we took a CBCT, and we can clearly see from the CBCT that the patient had had a previous root canal treatment on the 1-1 and also on the 2-2. When we look more carefully at the 1-1 site, which is this image, these images over here, we can see that the tooth 1-1 showed some apical resorption. Basically, the root tip was shorter than it should be, likely from the previous trauma and from the root canal treatment. There was also a small infection that involved both the bone and the root, a classic perioendolesion lesion. Now let's look at the 2-1 site. The 2-1 site that can be seen on these 2 images had some bone atrophy, which is expected since this patient had lost this tooth approximately 10 years ago, according to the history. The good news was that the residual bone quality on both sides was pretty good, and we had solid foundations for implants. Small side note was that as a coincidental finding of this CBCT, we found a soft tissue density in the nasopharynx, so I referred John to an ENT just to be safe. It's always good to keep an eye on the bigger picture. So the next logical step in this case was that we took diagnostic study models and we had to very carefully remove the 1-1, curate out the granulation tissue. We placed a little bit of Geistlich bioos into that area, placed the collagen membrane and carefully sutured the area, placed the patient into an upper immediate partial denture as a provisional measure. Let's have a look at that. So this is the upper horseshoe-shaped immediate upper partial denture that we placed at the time of the extraction of the 1-1. We placed bios into that area, covered with a collagen membrane and sutured closed. I placed a clasp between the 1-5 and the 1-6, 2-5 and 2-6, and the fitting surface of the 1-1 and the 2-1 were bullet shape. I'll show you a view of that in just a second. This is the front view of the upper immediate partial denture. From the outset, I didn't like the color of the two temporary crowns that we placed in this area. This was done specifically for a reason. I'll get back to that in a minute. The fitting surface of the 1-1 and the 2-1 were bullet shape, and we can see the two clasps in that area. We maintained the anterior open bite as per the patient's desires. The patient stated that he wanted these two central incisors very white, and I tried to show him what his desire looked like in his mouth. It was a starting point because he realized that he needed to manage his desires to be able to create the best possible outcome. We also can see that the patient still has mamelons on the lower central incisors. These are usually gone, as we all know, between ages 16, 17, 18 max. But because he's not functioning in this area, his mamelons remained retained. So everything ran smoothly and the patient was given instructions to return after a week. We saw him after a week. Everything was looking like it was healing perfectly. Tissues were nice and pink. And we gave him further instructions to return 3 months later, where a fresh cone beam X-ray was taken. And let's look at those images. So in the 1-1 site, from a buccal to palatal direction, we had 5.95 millimeters of bone. We can still see a little bit of the bios in position. And we had lovely length. We had 18.91 millimeters of bone this area. And as a result of that, we planned to place an Ostem US 3SA 3.5 millimeter in diameter by 11.5 millimeter internal hex implant in this position. For tooth 2-1, it was a little bit more complicated. Though we had lovely length, we had 16.4 millimeters of bone length. At the coronal aspect of the bone, we only had 1.8 millimeters of bone width in this area. The bone was much narrower. So the plan was to do a pilot hole and to then use osteotomes to expand this area so that we could place a 3.5 millimeter in diameter by 10 millimeter Ostem US 3SA internal hex implant in this position. Let's look at that in 3 dimensions. So here we can see the implant planning, and as far as the 1-1 was concerned, that was pretty straightforward. The 2-1 is where the challenge presented itself. For tooth number 2-1, the bone was narrower and we knew that we had to go deeper, but we also had to be very careful in regards to the proximity with the 2-2. And this is of particular importance. You don't want the implant to come too close to the adjacent tooth. There still has to be enough viable bone into that area, and also that one doesn't encroach upon the apex of the 2-2. This is what it looked like in side view. We realized that we would have to expand the bone in order to create enough bone in a buccal palatal direction. We planned to wait for 3 months for osseointegration, then to check the implants for stability with an Ostel ISQ, and if all was good, we'll place 2 separate zirconia crowns in the 1-1 and in the 2-1 site. And yes, there always has to be a plan B. And plan B was that if for whatever reason the implant stability was not optimal, we discussed with the patient, or if the gingiva was not optimal, that we would place him into provisional acrylic temporary crowns until we had sorted out the stability of the implants and or the gingiva before we placed the definitive zirconia crowns at the end of the treatment. This is the pre-op study model, and one of the key takeaways is to always go very carefully through the history, including and especially if the patient has had trauma, to ensure that none of the adjacent teeth have any residual trauma that manifests only much later in their case, especially if there's been root canal treatment on any of the adjacent teeth or any kind of orthodontic work. This was a lower study model of the patient, and we can see that the patient had a little bit of crowding. And now let's look at what that looked like in the mouth. Intraorally, this crowding had presented with a little bit of plaque and calculus buildup. I had a chat to the patient and to the patient's dentist for him to clean this up. And there was some ongoing work in the 3-6 and in the 4-6 position, which the dentist that the patient was attending to do his general work was going to resolve. The left side view of the patient's bite, we can see that he had a perfect occlusion posteriorly and an anterior open bite. CBCTs are crucial in any kind of implant case because they assess the quality and the quantity of the bone and any hidden pathology. This is the right side view of the patient's mouth. And finally, always have a contingency plan for implant stability or soft tissue management if things don't unfold exactly as we like. And that's a wrap for the first part of this patient John's case. In the next part, we're going to start with the fun work, which is the surgical intervention.